not a lot of interest has been paid to over the course of the years. And so as an organization, this is an area where we have decided that Anglophone West African lives matter. And then if we can play in this space and bend the curve of life and improve outcomes for patients who have dyslipidemia, then this is an area where we would like to play. So thank you again for being here, and many thanks to our speakers for supporting us, for walking this journey with us to shape the landscape. So wish you a very fruitful deliberation. Thank you again. And then we are always on hand to support you on this journey. Happy to answer questions or comments as they come along, and wish you a very successful meeting. Thank you very much, Sam, and back to you.
Thank you very much, Ewande. Moving on, I will be introducing the first speaker of today. Our first speaker is Professor Karaye. He's a professor of medicine at Bayo University, Kano, and also a consultant cardiologist at Aminu Kano Teaching Hospital. He's an affiliate member of the Department of Public Health and Clinical Medicine of Mir University, Sweden. He's also an affiliate member of the Cape Heart Institute, University of Cape Town. He's currently the vice president of the Nigerian Cardiac Society. So please help me welcome Professor Karaye as he takes us on our first presentation. Over to you, Professor Karaye.
Thank you very much.
Prof, you're muted.
Okay.
Better now. We can hear you now. Thank you.
Okay, we can hear you now. Yeah.
Very good. So let me see if I can share my screen.
Your slides were up before.
Yeah, there are a few modifications. I was hoping to.
Okay. All right.
Yeah. Just a minute. It's a bit slow, but I think it will come up soon.
Okay, we can see your screen, sir.
Okay, very good. Okay, so thank you very much for the kind introduction. So I'll be speaking on expert strategies for dyslipidemia management. I'll start with this disclaimer. Kindly note that the views and opinions of myself do not necessarily reflect those of Novartis. And I've been asked to speak on this outline shown on the slide, starting with an introduction, then going through gaps in local practice compared to international guidelines in lipid management, down to the summary. So first, the introduction. Let me start with this classification of hyperlipidemia. You recall that hyperlipidemia is classified as either familial, also called primary, or acquired, which is also called secondary. Familial hyperlipidemia is caused by specific genetic abnormalities, while the secondary type results from other underlying disorders that ultimately lead to alterations in plasma lipids and lipoprotein metabolism. Familial hyperlipidemias can be classified into 5 types, types 1, 2, 3, 4, and 5. And the genetic defects are shown. I hope you can see my cursor there. Those are the defects, genetic defects. And by far the most common is the type 2, which is further classified into 2A and 2B. 2A is what is called familial hypercholesterolemia, while 2B is called familial combined hyperlipidemia. FH is the most common autosomal dominant disorder, and it is characterized by high LDL cholesterol levels and elevated lifetime risk of coronary heart disease. It affects up to 30 million subjects worldwide, but this figure is considered gross underdiagnosis, particularly in Africa, and I'll speak more a bit more about this. It is caused by mutations in the genes that regulate LDL catabolism, mainly the LDL receptor and apolipoprotein B receptor, but also gain of function mutation of PCSK9 receptor. But in 20% of affected patients, multiple genes are available, are present, while in some individuals, no molecular defects are encountered at all, and this is called FH phenocopy. The genetic mutations are shown for heterozygous and homozygous forms of the FH. For the heterozygous, in fact, is quite common, seen in about 200 to 250 individuals in the general population, while the homozygous is rare, seen in between 160,000 to 320,000 persons in the general population. The homozygous is associated with very high LDL cholesterol levels, much higher than what is seen in the heterozygous form of it. FH is diagnosed based on clinical presentations, and there are clinical criteria for this. The most common is Dutch Lipid Clinic Network, which is shown on this slide. As you can see, there are 5 domains: family history, clinical history, physical exam findings, mainly skin manifestations, and then absolute LDL cholesterol levels starting from 4 millimoles per liter up to more than 8.5 millimoles per liter, and there are scores for all this. And there are also scores for genetic mutations. Ultimately, the scores, the numbers are added, and people that score more than 8 are considered to have definite FH. Scores between 6 to 8 points for probable FH, and then 3 to 5 points for possible FH. And you agree with me that majority of the patients with coronary artery disease that we see in our countries actually are premature, men aged between less than 55 and women less than 60. And you also agree with me that many of our patients actually have cholesterol levels between 4 to 6.4, that's LDL cholesterol levels. And therefore, we just need to look for the skin manifestations. All these are in keeping with the skin manifestations of FH. Secondary dyslipidemias are caused by many conditions, diabetes, but also the common drugs that we use to treat hypertension, like diuretics and beta blockers, particularly the older beta blockers, but also contraceptive pills. But so many other conditions, hypothyroidism, renal failure, excess alcohol, all can cause secondary dyslipidemias. How about the epidemiology of dyslipidemias? This is data about 3 years old on the global epidemiology of dyslipidemias, and the estimates of total cholesterol in the general populations in sub-Saharan Africa is shown relative to those in the Western Europe and high-income North America. And as you can see, our cholesterol levels are much lower, significantly lower when compared with the global average, but also in particular lower than what is seen in the Western Europe and high-income countries. But what is notable is that whereas if you compare the levels, say globally or in the Western Europe and high-income North America, the levels are lower in 2018 when compared to 1980. You see that our own levels in sub-Saharan Africa are actually increasing, and this is not good. This is something that we need to pay attention to. Regardless of this, our prevalence of dyslipidemia is considered to be less relative to what is in other parts of the world. and it seems to follow compared to high income levels. And this is an estimate of the prevalence of dyslipidemia among adults in the general population of sub-Saharan Africa. We estimate that about 25.5% of our population have elevated total cholesterol, even higher if you define dyslipidemia using elevated LDL cholesterol. We did meta-analysis back in 2012 in being a lot of work to do to try to improve on this, try to detect more cases. This includes assessment of FH opportunity during all related clinical consultation. Say if with malaria, make attempts to also do this during routine health checks or patients. So all this will help us to try to, improve on there a strong relationship with atherosclerotic cardiovascular disease? The answer is yes. We know that for sure that LDL cholesterol causes atherosclerotic cardiovascular disease, and sustained exposure to LDL cholesterol results in retention of LDL particles or atherosclerotic plaques, and the growth of these plaques is proportional to the concentration of circulating LDL cholesterol as well as other ApoB containing lipoproteins such as Lp(a). And when these plaques rupture, acute events occur such as myocardial infarction and ischemic stroke. And we also know, I showed this slide earlier, that the prevalence of FH in patients with ischemic heart disease that of that is seen in of FH. Hello? Hello?
No worries, sir. Please, you can go ahead, please.
So detection
Thank
of
you.
FH mutation is also important because if patients have high therapies like ezetimibe, inclisiran, and so on, so that we can meet the treatment goals. But we should know that response to certain treatment is variable. Therefore, before we consider adding additional treatment, include adding, say, ezetimibe to statin, we need to up-titrate the statin dose because there are variations in response to statins between patients. Now, to assess total cardiovascular risk, and this total risk is, we are talking about 10-year risk prediction model for fatal and non-fatal cardiovascular disease, in particular for MI and stroke. And the WHO has come up with both non-laboratory based charts and laboratory based charts. And these are available on mobile apps, so you don't need to memorize anything. This is for the non-laboratory based risk. The only difference is that lower down, you see body mass index used in place of promoted is considered to be better, more than body mass index. So basically, it's based on gender, men or women, and smoking status of the individual, and then the age range of the individual, where the age, estimate the age, and then blood pressure on the other side, systolic blood pressure on the other side, and then the body mass index. And on this, you can also see the model using LDL cholesterol for patients who have diabetes and those who do not have diabetes. So this is better model. Whatever case may be, we should estimate the total cardiovascular risk. Patients who already have documented vascular disease, such as or acute syndrome or coronary vascularization, diabetes with target their chronic kidney, they already, so they are already, in fact, no need to spend more time estimate determine the treatment cholesterol, because that is the target for treatment. For patients who are very high risk, we need to target 1.4 millimoles per liter or lower. Those at high, we need to target 1.8 millimoles or lower. And as you can see, those low, we can even allow a higher LDL cholesterol level. The way to treat is that after determining the risk, after determining the LDL cholesterol level, and after making up our mind that we need to treat the patient with drug therapy, and the time defining the treatment goal, then we need to start a high potency statin at highest recommended tolerable dose and try to see if we can achieve LDL goal within 3 months. And then we can now up-titrate and then consider adding additional therapy. When we say high-intensity statin therapy, we're basically talking about 2 drugs, atorvastatin at a dose of 40 to 80 milligrams per day, or rosuvastatin at 20 to 40 milligrams per day. And then we should expect that high-intensity statin alone, if patients respond and they follow the treatment as prescribed, we should expect up to 50% reduction in LDL cholesterol. But when we add additional therapies, we can see that there is significant improvement in the reduction in LDL cholesterol over time. But we should know that there are certain factors that also impair adherence and the achievement of the treatment goal, particularly factors such as pill burden or the number of injections we give, for example, monoclonal antibodies as compared to inclisiran, which has only 2 injections. I mean, there would be difference in adherence and also ultimately in achieving the treatment goal. Now, this is a study called the ACE study that reported the prevalence of CVD risk factors in more than 4,300 outpatients. And they recruited patients from across Africa, including Nigeria and Ghana, from our outpatient clinics. And they found that up to 39% of the general population of the patients they studied would need statin therapy. The need may be higher in patients above the age, up to 70% of males, up to 44% of females, and more above the age of 60. You can see the need for treatment. So lipid lowering. This is data from just around on the average Nigeria and about that around about. But there are roadblock factors that to affect to management and treatment of cholesterol levels. There are some that are considered level, access to health or people, remote, or there are some at physician level, so lack of awareness among physicians, screening, and also lack of knowledge on lipid lowering treatment, and some at health level, such as lack of optimal screening programs, or shortage of facilities in our cities. And this is data related at primary health from Nigeria is one of have been to have facilities for testing lipids, PHC, which means that they seem to have those facilities, PHC levels, gaps by offering oil. Novo made such an effort. This is both and then I'm sure they will share this algorithm with you, so you can study it at your convenience. We adopted the WHO CVD risk-based chart, which I showed earlier. Now, what is the efficacy of inclisiran and safety as an add-on treatment? Now we know that inclisiran is a double-stranded small interferon RNA that suppresses PCSK9 translation in the liver, leading to sustained reductions in LDL cholesterol, but also of other atherogenic lipoproteins, including Lp(a). It's indicated at the moment in patients with primary hypercholesterolemia or as an adjunct to treatment when other treatments like statins fail. So it can be given alone or in combination. It is the first and only therapy that utilizes the small interferon RNA mechanism and is highly effective, provides sustained LDL cholesterol lowering over the course of extended dosing interval. And it does this regardless of body mass index, whether patients are on background therapy or not, or its intensity. Is equally effective in almost all circumstances. And as you can see on this slide, studies have shown that maximal reduction in LDL cholesterol is achieved within the first 90 days of treatment. So by the second dose, by the time you give the 3 months dose, the achievement, the goal of LDL, the target LDL cholesterol goal is already achieved by that time. So it's highly effective. Now, is this safe? The answer is yes. Studies have shown that it is well tolerated. The safety profile similar to that of placebo. Quite surprising, but that's the fact. And the rate of discontinuation were also quite low. And there are ongoing cardiovascular outcome trials that would now provide additional information on its long-term safety, as well as its influence or effects on CVD outcomes. How is it administered? First of all, you give the first dose, 300 milligrams subcutaneously. You give the second dose at 3 months, and then every 6 months thereafter, which means twice a year therapy. So it's a strong complement to statins to achieve effective and sustained LDL cholesterol reduction. To summarize, I'd like to say that ASCVD is the leading cause of cardiovascular disease, morbidity, and mortality, and current evidence to a significant improvement in cardiovascular outcomes regardless of the lipid-lowering therapy used. Many patients treated with statin-based lipid-lowering therapy are unable to consistently achieve and maintain their LDL target goals. Inclisiran, the first and only therapy that utilizes the small interferon RNA LDL cholesterol, mimics the body's process of RNA interference to increase LDL receptors from the circulation is effective and provides sustained LDL cholesterol lowering. Side effects were few, mainly transient skin reactions, and it's appropriate for people with elevated LDL cholesterol levels who do not achieve guideline recommended thresholds with statins, and is given at the beginning and then after 3 months and then every 6 months thereafter. And I think that is the last slide. So thank you very much for your kind attention.
Thank you very much, sir.
Thank you.
Thank you very much, Dr. Professor Karaye. Thank you for the very insightful presentation. And we will take questions after the second presentation by Dr. Doku. So Dr. Doku is our next presenter. Dr. Doku is a Ghanaian and German trained cardiologist. He is a senior lecturer and head of cardiology at the University of Ghana Medical School and Kolebu Teaching Hospital. He is well published with more than 18 publications in peer-reviewed journals. He is a fellow of the Ghanaian Society of Cardiology. He is a fellow of the West African College of Physicians and a fellow of the German Cardiac Society. He is the immediate past president of the Ghana Society of Cardiology, and he is the present and current director of the African Air Ambulance Foundation. So I'll hand over to Dr. Doku to present on optimizing outcomes in ASCVD. Doku, over to you.
All right. Thank you very much, Evelyn. Thank you, Prof, for setting the pace. I think most of the things you mentioned, I can appreciate them. So thank you very much. And thank you, Novartis, for inviting me. Please, can you hear me?
Loud and clear, sir. We can hear you loud and clear. Thank you, sir.
Okay. Can you see my slide?
Yes, it is up now.
Yes,
We
please.
can see it.
Yes, please.
Okay. All right. Thank you very much. So my task is to talk about how we could optimize patients' outcome, patients with the ASCVD. What I will say is that Africans have not woken up to the reality that we are dying a lot more from ASCVD than non-ASCVD, non-atherosclerotic cardiovascular diseases. So we're still thinking that, yes, we're dying more from hypertension related directly or infectious base, where we're getting rheumatic heart disease, cardiomyopathies. We're getting more of endocarditis and all these as the main causes of cardiovascular diseases. We're getting hemorrhagic strokes or aortic dissections and all these. Yes, we're getting all these, but there's actually a transition, from the non-atherosclerotic cardiovascular diseases to atherosclerotic cardiovascular diseases. The data which Prof has shown, I will also be showing some of them. So it's a major problem, and across Ghana, we're getting a lot more patients with the ischemic stroke, a lot more patients with myocardial infarction, peripheral artery disease, ischemic events in the mesenteric arteries. So it's a major problem that has come up, and we need to optimize patient management so that we can reduce the incidence of infarctive stroke, ischemic heart disease, and then the other ASCVDs. So how do we optimize these patients? First, I want to talk about my disclaimer. So whatever I present here are from my own research, from my scientific, opinion. There's nothing from Novartis. Okay, to kickstart my presentation, I want to make a short, case presentation to really highlight that how common ASCVD are. Where I work at the National Cardiothoracic Center, we have a cath lab, so a team of cardiologists every now and then are called, to attend to patients with a heart attack or a chronic coronary syndrome. About heart attack or acute coronary syndrome consists about 20% of the cases we do in the cath lab, and in the chronic coronary syndrome about 80%. And so we do these elective cases when they're available, but we are called in the middle of the night to attend to patients, weekends, attend to patients who present with acute coronary syndrome. In the past, we didn't have these number of cases, but we're getting a lot more. Accra alone, we have 6 cath labs, and we are getting busier by the day. So that tells you the burden of myocardial infarction, what we're getting here in Ghana. And I don't think it's only in Ghana, but it's across West Africa, across Sub-Saharan Africa. So ASCVD is a major problem, and we need to optimize the patient care. So this is a young patient, 44-year-old lady, hypertensive for 5 years. She has CKD, stage 3B, and she's had 2 previous strokes, infarctive strokes. So based on the secondary prevention strategy, she's been put on high-dose statin, atorvastatin 80 milligram, clopidogrel 75 milligram as a secondary preventive measure to control the blood pressure, and also the benefit of ARB and then ACB inhibitors. Put on candesartan 8 milligram. He was a bit overweight, BMI 32, blood pressure 144/84, and then he had impaired glucose So hemoglobin A1C 6.3 and LDL not so much to target 2.9. So she presented to us in the middle of the night with inferior STEMI. So we did a coronary angiogram which showed a codominant system with acute thrombotic occlusion of the left circumflex. The picture you see is not her picture, just to make sure that we don't show her images here, but it's similar to what you see. It's a codominant system, and you can see the circumflex. The circumflex, okay, we'll see this is the third obtuse marginal, a huge one with the lesion at the ostium atherosclerotic plaque there, and then this is where the clot was, to speak, and you can see 90% stenosis. So in the middle of the night, we had to do a PCI to put in two stents, which had a good flow after the stent implantation. Echocardiogram showed that yes, the ejection fraction is well preserved. The question then is, what next for this patient? She's on some optimal medical therapies where statins are concerned, but LDL cholesterol is not to go. Her BMI is 32. What should be the LDL level? So I'll come back to this case, but let's first look at a few things. So is this case a rare case or is a common case across sub-Saharan Africa? As I mentioned, we've seen a lot of ischemic stroke. We've seen a lot of myocardial infarction across Ghana and across the rest of sub-Saharan Africa. So this is not just a rare case. We're seeing them on a day-to-day basis. ASCVD is common in Ghana. Cardiovascular disease, the main causes of death. So if we look at the national data, cardiovascular disease is the number one, number two main causes of death. So it's between stroke and heart failure. So one particular year, heart failure will lead, another year, stroke will lead, and be leading for the last 10 years. And it's the same across Africa. And worldwide, cardiovascular disease is the main cause of death, killing about 20.5 million people by world heart federation. And unfortunately, about 80% of these deaths occur in the low middle income countries. The other question is, if you're getting ASCVD, how or why are we getting them? Are the risk factors for ASCVD common? So that's something we also need to answer. So three things I've asked here: how common is ASCVD in Africa? And as I mentioned, from data and from experience on the ground, we're getting a lot of ASCVD. In the past, infarctive stroke, hemorrhagic stroke was the main cause of stroke in Africa. But data now show that about 68 to 70% of strokes in Africa are due to infarctive strokes. And then we're getting a lot more ASCVDs across scaling people, especially young people. You see, this patient is 44 years old. You would think that, yes, as in the Western world, those who develop ASCVD will be in their 60s, 70s, 80s. But the productive age group of the African are affected the most, affecting families, affecting society, the breadwinners of society. So our type of CVDs and our type of ASCVD are coming down to people who are really still in active service and serving their families. So it's a big problem. So the case I've just presented is not an isolated case. Indeed, these are the leading causes of death. And how can we optimize? That's my topic. How can we optimize outcome so that what's happened to this lady with a STEMI coming in the night can be prevented? Well, this will be my outline. I'll talk about the burden of the ASCVD and then what individual risk stratification will do to help target the treatment so that we can have a better outcome. We'll also look at the risk factors, especially in Africa, and how do we improve on them. So let's look at this we've always had this idea that cardiovascular disease mortality is around 17.9%, a million people dying, but I was surprised to see this from the World Heart Federation reports 2023. It showed that we have about 20.5 million people dying in 2021. So a lot more people are dying from from cardiovascular disease than we thought. And this constitutes about a third of the global death. And most of these deaths occurred in the low middle income countries. What did the World Heart Federation say about the causes of these mortalities? Elevated LDL level, high blood sugar, environmental pollution, high body mass index, tobacco use, and then low physical activity, and then raised blood pressure. So these are the things that are common in the world, and especially in the low middle income countries. That's what is contributing to the 20.5 million people dying from cardiovascular diseases. And most of these, as I'll show later, are due to ASCVD. Indeed, ASCVD constitute about two-thirds of the global CVD death, so about 67%. This is a report from the American Heart Association and the American College of Cardiology showing the trend in ASCVD deaths. And you can see that ischemic heart disease mortality and ischemic stroke mortality constitute about 67%. And then that has been the trend over the last 10 to 20 years. So global death is mainly from ASCVD, and ischemic heart disease is a major problem. And what I tell my fellows or my residents is that patients who die from ischemic heart disease or from acute coronary syndrome, 50% die within the first 1 hour. And if you look at most countries around the world, in Europe and America, they've built an emergency system, around acute coronary syndrome, where within 5 minutes, these patients need to be reached. But how much capacity have we built in Africa? This patient who saw us, which I just presented, so then she came to us driving, the family drove her in, most people in Africa don't have adequate or properly structured pre-hospital care. So how can we improve outcomes in a continent, that predisposed to having this ischemic stroke, acute coronary syndrome? And for ischemic stroke, within 4.5 or 4.5 hours, CT scan needs to be done, and if it's an infarctive stroke, you thrombolize this person, and you have a better outcomes. You reduce neurological deficits. Within 3 to 6 hours, if a patient comes to you with STEMI and you're not ready to do PCI, you can thrombolize these patients. But how many of us have the facility to do a quick CT scan, to do thrombolysis, or to have a cath lab to be able to do a PCI? So it's a major problem that we need to deal with. But that's another thing that we can discuss. As Prof said, elevated LDL-C level is really the primary cause of ASCVD. So you have this plaque buildup, you have the oxidized LDL that gets internalized, and then this plaque formation, this plaque grows. Now, depending on this person's risk factors, how well, blood pressure is controlled, the obesity, diet, exercise, this plaque may be stable or unstable. So if this plaque is unstable, this plaque can rupture. So this person, if this plaque is in the coronary artery, as it grows, if it's stable, the person will continue what we call chronic coronary syndrome, where the symptoms are more stable. But if this plaque is not stable, then we have plaque rupture leading to acute coronary syndrome with catastrophic consequences. So as I mentioned, you have this plaque buildup over years. If this plaque is not stable, then you have plaque rupture, fissuring or erosion, platelet aggregation, and then you have a clot formation. And this behavior of these clots in the coronary artery, for example, would tell me whether this is a patient who present with STEMI, N-STEMI, or unstable angina. About 30 to 40% of acute coronary syndromes are due to STEMI. And again, how much capacity have we built as a continent able to manage acute coronary syndrome or ASCVD when it comes in? So how big is this burden of ASCVD? As I mentioned earlier, most of us think that, yes, we're looking more of hypertensive heart disease, we're looking more of, valvular heart diseases as the main cause of cardiovascular problem in sub-Saharan Africa. But this is a slide showing the burden of cardiovascular disease as compared to the Western world. And it shows clearly that ischemic heart disease and stroke, are the main causes of death. Remember the global burden that I showed, which showed that about 67% of cardiovascular mortality are from ASCVD. And so let's look at this in Africa. So ischemic heart disease, most of which 70 to 80% are due to atherosclerotic cardiovascular disease. And you look at stroke, which I'll later on show that 67% of strokes are infarctive strokes. So indeed, ASCVD is the main cardiovascular disease in sub-Saharan Africa. And we need to modify these risk factors to be able to get the appropriate outcomes. And so this is the slide I was referring to. There was 68% of strokes in sub-Saharan Africa are due to ASCVD or due to infarctive strokes. How have these, changes come about? Over time, Africans, sub-Saharan Africans are dying more from this ASCVD than previously. So you can see that ischemic heart disease and stroke from 1990 to 2017 increased by about 71%, about 40% from stroke. And if you look at peripheral artery disease, about 154%. Now, another slide from Mensah and colleagues also showed that from 1990 to 2013 in sub-Saharan Africa, ASCVD has also been increasing, where ischemic heart disease increased by 87% and ischemic stroke by 104%, and peripheral artery disease more than double. So what is the trend? What is going to happen in the next few years? Ischemic heart disease is going to increase because Africans are going to have more of these risk factors, as Prof mentioned. PLC levels are going to go up. Obesity is going to go up as we all move. Most of us move from the villages to the cities. Some will smoke. Will be exercising less. Blood pressure will be uncontrolled. Sugars will be controlled. So we're going to get a lot more. But how do we optimize and also reverse these outcomes? So first, you need to risk stratify these patients. The patient, anybody who comes to you with a suspicion of ASCVD, you need to do risk stratification so that you'll be able to manage their risk factors properly and be able to have a better outcome. So this slide is more left from the one slide that the Prof showed earlier on, the European Society of Cardiology, and then the other partners, the dyslipidemia recommendation 2019. And so when you have a patient in front of you, you have three types of patients. There's a patient who apparently is healthy. You need to calculate the 10-year CVD risk or ASCVD risk. And then you have a second group of patients who will have established ASCVD, who have, a plaque in the carotid or the peripheral artery, or CT coronary angiogram, or may have had an event already, had an ischemic stroke, or may have had a myocardial infarction. Or this patient, a third group, they may also have, end stage or target organ damage, so may have CKD, or may have diabetes. Diabetes has the CVD or ASCVD risk equivalent. So these are the three types of patients you're likely to see, and you need to risk stratify them. Again, you need to also look at the population. We tend to look at the individuals in Africa, but as I mentioned earlier on, the whole continent of Africa, sub-Saharan Africa, is at risk. And we need to look at population-based interventions to be able to optimize ASCVD care. But for the individuals, either the person that hasn't had an event where you have the parameters available, then you'll be able to calculate the 10-year risk, or the person has had an event. Here, you need to look at secondary prevention strategies and a patient with diabetes or CKD or familial dyslipidemia. And it's important that you see these patients down the population, that they discuss this risk with them. Now, if you've had a stroke, your chance of getting another stroke in the future is high. We need to come together. We need to agree. What can we do? What are the things we can do to improve? As the prof showed this, the non-lab WHO risk calculator for West Africa, and then the one with when you have the lab, we have the lipid level, we have the blood sugars, you'll be able to tell whether the person has diabetes or not, the person has dyslipidemia. And you can clearly show that as you move, from smoking to non-smoking, it turns red. And as you move from non-diabetic to diabetes, you have more. So it tells you that dyslipidemia, smoking, diabetes, these are the main drivers, of ASCVD. And so we'll be able to modify some of these, we're able to improve outcome. I'll put them together to be able to see the transition from somewhat green to more red as you move towards the right side, as you have more patients with diabetes and with dyslipidemia. So what are the guidelines saying? Well, we build capacity in Ghana to manage cardiovascular disease. In 2019, we developed the Ghanaian CVD guideline, and one of the chapters is on CVD risk, stratification and management. So we had the targets LDL level as has been recommended by the 2016 guideline. But at the time, the ESC 2019 guideline hadn't come out yet. So our targets LDL level for high-risk patient was 1.8, and then HDL level and the others were the same. Fast forward, we now have more data. We have more recommendations. So this year we're having what we call the focus update of the national CVD guidelines. And one of the recommendations or new updates we're doing is on the risk factors. So we are updating the risk factors, to improve outcomes. So a patient with a high risk, then the LDL level is now 1.4, as Prof mentioned earlier on. And then how do you achieve this if you're not able to get to target with high statin dosage, for example, atorvastatin 80 milligram and the Oribal's Crestor, as in we can't get to targets, then you do think about ezetimibe, or we can look at inclisiran, which is available here in Ghana. So the guidelines have changed, and very soon this focus updates for the Ghanaian Cardiology Society, Ghanaian CVD guideline become public. So within the next 1 month, that will become public. Okay, what are the international guidelines telling us? So this is the EASC. So this is similar to what Prof mentioned. But I want to add that if a patient who has a very high risk factor, and then has had 2 events in the last few years, the last 2 years. So this patient now presented, she's had strokes in the past and now comes down with a heart attack. So this patient then falls within the side of the risk. So very high risk with recent events. So her LDL level is 1.0 or less. So this somebody you need to really optimize the LDL management to be able to achieve targets. So back to this case that I presented, it's a patient who's had previous strokes, who has CKD 3B, who presented as a BMI of 32 HbA1 of 6.3. Blood pressure is well controlled. LDL-C, as I mentioned, supposed to be 1.0 or less. It's 2.9. Presented with the STEMI. Why did she develop the ACS? So that's a question I want to ask. So what will be the next line of action for this person? What will be the LDL-C level? It's known that despite the use of effective secondary prevention strategies, 5 to 10% of patients with cardiovascular disease would have recurrent events, as happened in this patient. So it means that something is not right. We are not doing something right, And what could account for this, and how can we improve on this? Compliance is an issue, and it's well known that patients on statin by 80% are not compliant. Patients, we tell them to exercise. Do they actually exercise? Do they maintain the ideal weights? Are they compliant on the statins, as I mentioned? Are they compliant on antiplatelets? This patient has been on clopidogrel. How well does she take the clopidogrel? How well does she take a statin? So these are things that we need to improve. We need to sit down with these patients. We want to have or want to improve on outcomes. LDL-C level for these patients supposed to be 1. Hence, is far from that. Blood pressure is not to target, so something we can optimize. Hemoglobin A1C is 6.3, which means that she has impaired fasting, impaired glucose control or glycemic control. So this is something that can be improved to optimize outcomes. So clearly there's evidence to show that if a patient is able to lose about 0 to 5% of the body weights, you reduce hypertension, you delay hyperglycemia, you reduce hyperglycemia. 5 to 10%, you prevent type 2 diabetes, non-alcoholic fatty liver disease, and dyslipidemia. So as the patient reduces more weight, and this patient, the BMI is 32, you're able to reduce the hemoglobin A1C, be able to reduce the lipid level to some extent, you're able to also reduce. So there's an opportunity for us to optimize this person's weight, reduce the BMI from 32 towards about 25 to be able to have the best outcomes. It's also shown that lower is better, not only the weight. Every 1 millimole of LDL-C reductions, I told about 20% reduction of CVD events. And this has been demonstrated in several researches, several systematic reviews. And so this person is at a high level of LDL-C, be able to optimize and bring it down, about 2 millimoles, you have about 20% reduction in the risk. And also known that if you're able to reduce the hemoglobin A1C by 1%, you have about 21% reduction in diabetes-related events. And as you and I were, 80% of the diabetes patients die from CVDs. And if you're able to reduce blood pressure by 10 millimeters of mercury, you're able to get about 20% reduction in major CVD events, 35% reduction in stroke, and 40% reduction in heart failure. So this patient will be able to do a lot more, optimize some of these secondary prevention strategies, then we'll be able to improve on her outcome. So progression from chronic coronary syndrome, to events depend on how well we optimize. So patient with chronic coronary syndrome, they'll be able to optimize care, then the risk reduces from top here, cardiac risk or event reduces from the red up here down, so the patient gets revascularization, you optimize secondary prevention strategies, give aspirin, give a statin, the ARBs, then the person's chance of developing acute coronary syndrome and symptoms reduces. But if these things are not optimized, then the person will have worsened chronic coronary syndrome with angina, or the person will have intermittent acute events, acute coronary syndrome. So lipid therapy can be optimized. This lady is on optimal statin level, atorvastatin 80 milligram. Despite the laser, she's compliant, we're still not to target. So what are the guidelines saying for optimal LDL-C level? So intensifying the lipid lowering level. So the guideline recommends that you give high intensity statin, especially for high risk patients, which will give you about 50% reduction or more in LDL-C level. Now, if you're not to target, as in this patient, there's possibility, or the chance to add ezetimibe 10 milligram that will increase this reduction to about 65% or more. Now, if this patient, for one reason, is not tolerating statin or ezetimibe, you're giving PCSK9, for example, in glycerin, you have the chance of reducing the LDL-C level by about 60%. Now, if this person tolerates ezetimibe, statin, yet you're not getting to target, then you can add this as a third agent in glycerin to have an optimum LDL-C level targets achievement. And so these three wise men will come together. The statin, ezetimibe, PCSK9 inhibitors are recommended to get to the level of the LDL-C level. So back to this patient, how do we optimize ASCVD outcome in this patient with a very high risk, who's had two recent MI with the two previous ASCVD events that infarctive stroke. So this patient, we need to talk to this patient. The diet is the key. Exercise a bit to reduce glycemic blood sugar level with a view to reduce LDL-C level, with a view to reduce weights. Stress is important. How do we simplify our lives, so that we can have optimal CVD outcomes? BMI for this lady, she was moving from 32 to 25. And then the blood pressure, we can come to 130 systolic or below. That would improve outcome. As you saw earlier, on 10 millimeters of mercury reduction in blood pressure, confers a significant reduction, 20% all-cause mortality, about 35% reduction in strokes, about 40% reduction possibility of having a heart failure. A1C it's 6.3. Can we bring it down below 6% through diet, exercise, weight reduction? LDL-C is more than 2. Can we bring it down to 2 or less with optimal blood pressure or optimal LDL-C? With ezetimibe, the statin is already on atorvastatin 80, ezetimibe 10 milligram, and then in glycerin 300 milligram injection first, injection, a second injection 3 months, and then every 6 months for some time, be able to get the LDL-C level to target. Now, through the COMPASS trial, we're told that rivaroxaban is able to also improve CVD outcomes, with aspirin to rivaroxaban. So this, we could wait, because now she's on dual antiplatelet therapy. We could wait, and then maybe for long term, we'll consider adding rivaroxaban to aspirin and see whether that can improve. So there's a lot we can do to this patient. So this is how we can optimize ASCVD outcome, by optimizing care in the diet, in exercise, stress reduction, BMI, aiming at a lower BMI, BP, optimizing blood pressure, optimizing hemoglobin A1C targets, optimizing LDL-C, especially LDL-C level, because for the high risk this patient has. So to conclude, ASCVD is common, and as I mentioned, is the leading cause of CVD deaths. But to test of the CVD deaths, so if you're looking at 20.5 million people dying in a year, so then we're having about 40 million people as a result of either an infarctive stroke or ischemic heart disease. It is important to risk profile these patients, individuals, and to some extent the population as well, to which our population interventions with lifestyle changes to be able to, reduce CVD outcome. But for at the individual level, we need to risk profile them. What can be done? Is the LDSC to target? Is the weight to target? Is the blood pressure to target? Is the hemoglobin A1C to target? Is the person smoking? The person exercising? Is their diet appropriate? So once we do this, then we can improve the CVD outcome. And to conclude, lipid management is really very important. And we have three options. Apart from exercise, diet, we have three options, three-layered option of giving statins, ezetimibe, and a PCSK9 inhibitor. In Ghana, we have inclisiran, and I'm sure Nigeria will soon be having. So we have options in our bags, options that we can talk to patients about. So ASCVD is common, and we need to do our best to optimize outcomes to reduce mortality and morbidity, as you said with it. Thank you very much. Evelyn, over to you.
Thank you very much, Dr. Doku. I'll hand over to Samuel. Yeah.
Thank you very much, Dr.
Sam, we can hear you. Your volume is a bit low.
Oh, my apologies. My mic was off.
Good.
Can you hear me now?
Yeah, loud and clear.
Okay, thank you very much. Thank you so much, Dr. Doku. Really appreciate your presentation. It was very insightful. Thank you so much, Professor Karai. Those are really great presentations. Now we are going into the question and answer session. And if you've noticed, this is a special Lipid Academy, and you'll notice that it's especially for physician specialists. So the idea is that in this kind of forum, we can have really high level conversations, because as Professor Karai and Dr. Doku have really clearly stated today, it's a big problem that we now have on our continent. And of course, we know that presentations cannot see everything. So we know that in your practice and in your experiences, there are a lot of practical things that you would like to rub minds with other eminent specialists here about, and to get more clarity about, and probably maybe also drop some light from your own experiences that can enrich the practice of other specialists on the call. So we'd like to hear from you. So we're going to a session of question and answers and discussions for the next 20 minutes. If you prefer to speak, you can now unmute your mic to speak. But if you prefer to drop a chat, you can also drop a chat in the chat box, and then we'll read them as they come in. Thank you very much. So that is that. One last announcement. We have the links to the feedback forms in the chat. Please click on them so that you can give us feedback, and then also, more importantly, to give us the details so that you can get your CME points. The link for the Ghanaian doctors has been put in the chat, and the link for the Nigerian doctors have also been put in the chat. So we'd like to hear from you. What are your questions? Do you have any clarifications that the speakers can make? And then do you have anything that you'd like to add that you think would be noteworthy for other specialists on the call? We'd love to hear from you.
Okay, Sam, just to add this, for the CES host on our platform, you can also let us know of the questions that are coming on that platform so that it can be answered as well. Thank you.
Thank you very much. So do we have any questions, please? Do we have any questions or any contributions? And Dr. Doku and Professor Kari, I don't know if there are any other things that popped up in your mind that you would like to add, something that you think might be practically interesting or necessary for other doctors on the call to know.
Hello, Prof.
So,
Yeah, so
Dr. Doku, how are you?
I'm fine. Are you?
Yeah, I'm great.
So I'm wondering what capacity Nigeria is building for managing, strokes and heart attacks in an emergency situation. It's a challenge here in Ghana. ASCVD, as I mentioned, is very common. Last year, we had a national campaign where we created awareness on emergency preparedness with a call center, trying to make thrombolytics available, trying to, get people to do CT scan on time, able to refer people for catheterizations on time. And it's catching up a bit, but there's a lot of work to be done. So at the at Nigeria level, wondering what you guys are doing to support the care of ASCVD emergencies to improve patient outcome. Over.
Yeah, thank you for that contribution or question. I think probably we need to look at your model because right now we don't have such activities going on at present, to my knowledge, because it's worrying to us as well. As you know, particularly in where I live in northern part of Nigeria, we seem to have even higher, relatively higher prevalence of heart attacks compared to many other regions, as shown in one of the registries we've done called RACE registry for acute coronary syndromes. It seems we have even higher rates of MIs, at least acute coronary syndromes. I'm not sure for stroke, but definitely we need such campaigns as we are doing in Ghana. Probably you share with me the model you are using, and I think I will promote it in our Nigerian Cardiac Society. We have some activities going on at Nigerian Cardiac Society, but not yet for emergencies. We're trying to work on use of defibrillators in gatherings, in markets, and all that. We're trying we're working on that program. We've not yet launched it, but we'll have it on. We are considering it. But I think what you have done or you are doing in Ghana, in that respect, I think is worth looking at. Probably we may actually consider it. But we have a big problem in our hand. We have large burden of particularly ischemic heart disease and MIs. Strokes have been there all along, probably even getting worse. We've just finished a study on morbidities and mortality in 7 regional hospitals in Nigeria. I am the lead investigator there, and I can tell you, finish now. We'll soon look at what is killing people in our teaching hospitals. We'll have the answer very soon. But I can tell you that cardiovascular disease is on the lead. For that I know, because I took a quick glance at the data, but I can tell you we have a big job in our hands. But we need support of the government for sure. Your model, I'm sure, will help us going forward.
Okay. Thank you, Prof. We need to collaborate then. Yes.
Yes, we should.
That sounds like a great idea. More of that. We have a question in the chat. Dr. Kuli is asking, he first complimented your presentations and said they were very insightful. But his question is that ezetimibe and inclisiran were the only options that were mentioned in the presentations. He's wondering, what about fenofibrates? Are they not an option? So both of you can pitch in freely.
Well, there are options. Let me even share probably a slide that can shed light on that. But you see, when we are talking about high intensity lipid lowering therapy, they actually are not, the others are not in that category. I already mentioned that we are talking about high intensity statins, but they have a role. Particularly, I'm interested in heart disease in pregnancy quite a lot, and I can tell you that in pregnancy, bile acid sequestrants are probably best suited for such patients because statins, ezetimibe, PCSK9 inhibitors, inclisiran, they are all contraindicated during pregnancy and in fact during breastfeeding. So they have a role, but as you know, these presentations cannot answer, we cannot talk about everything. In fact, I was given only 20 minutes. So as you can see, we cannot talk much about everything. Okay, I cannot find the slide. It's not in this presentation, but bile acid sequestrants, they can actually reduce LDL cholesterol by almost 18 to 23, 25% themselves. So they are not totally useless, but we have better treatment. I showed you that high intensity statins can reduce LDL cholesterol by up to 50% over 3 months. So you cannot compare the achievement of target LDL using the two classes of drugs, but they have a role, like I just said. I've given you one good example during pregnancy, and we have patients that have, acute events during pregnancy or during breastfeeding, and one of the options you have is bile acid sequestrants like cholestyramine, yeah. Fenofibrates, well, yes, they are useful, but mainly for reducing triglycerides. So there are options, but I mean, we focus on the most important drugs. I don't know, Dr. Doku may say one or two other things as well.
Yeah, Prof, I agree with you. ASCVD, dyslipidemia is one factor, and there are other, comorbidities, and pill burden is one of the things that drive, non-compliant. So how can you tackle this in a more, effective way? And the current guidelines are clear. There are several other ways of going around it, but what is the effective, shortest way, so that you go straight to the point, give medications that have been shown to be more effective. Statin, have several benefits beyond LDL cholesterol reduction. And so those benefits also come in to reduce the CVD events, reduce thrombosis events, reduce inflammation, reduce C-reactive protein and all that. Ezetimibe, easy to take, less side effects, inclisiran injection, very safe. So there are several other ways of managing about which ones will give you the best. So that's why the guidelines recommended these key ones. So that's probably there are several other ones on the markets, but some of them have specific indications. But the most potent ones are the ones that are highly recommended to be able to achieve the optimized ASCVD outcomes. Over.
Thank you so much, sir. Those were pretty clear. Dr. Adeleye also has a question. She asked, she complimented your presentations and said they were very lucid. She's asking if you can speak to, he or she can speak to statin-associated myopathy. She says he or she says it's still a considerable challenge at high doses. So can you speak to statin-associated myopathy? So Professor Kari can go first.
Yeah, statin-associated myopathy is not as common as we used to think. There is, in fact, a study that looked at that closely, published in New England Journal of Medicine a few years back, I think a year ago, or two or 3 years ago. I think it's called N of, I think I've forgotten the title, but what it's saying is that people used to think that these statins, okay, it's called N of 1 trial, and basically what he's saying is that what they found is that in patients who had discontinued statin therapy because of side effects, 90% of the symptom burden actually elicited by a statin challenge was also elicited by placebo. 90%. And half of the patients who were enrolled in the trial were able to successfully restart the statins. So the issue is that a lot of these side effects are actually more or less influenced by so many other factors. But if you actually assess these things, objectively, in a trial situation as they did, you find that it's not as common as one might think. So a lot of the time, patients seem to know about these side effects, and they seem to assume that every little thing is actually, caused by the statin. So we need to disabuse patients, minds, against these things, because I mean, this trial, which is well conducted and published in the New England Journal of Medicine, has shown clearly that, in fact, some of these things that patients think is the statin that has caused it, actually placebo does the same. So I would say that they are not as common. And in my practice, I use great majority of my patients are statins, and I really don't see it, not as you put it, that it's a challenge. I'm not really finding that in my practice. So thank you, and over.
Thank you, sir.
Thank you, Prof. I think that is very true. People read the side effects, discuss this with friends or family members, so they are really prejudiced before even they start. And then those who have objective myopathy, muscle pain, who have objective hepatitis or renal impairment, these can be, so creatine kinase, for example, will help to know whether there's some inflammation to the muscle. Liver function tests can help, and then doing renal function tests before, and then also monitor some of these patients. But it is more of idiosyncratic reaction, to these medications, and vary from person to person. Some of them, as close to 90% of them, really the similar reaction to placebo. Having said that, there are some people who will not tolerate. That's why the guidelines are clear. For those who are statin intolerant, there are other options where they can be given ezetimibe, or they can be given PCSK, alone, which will give you about 65% reduction in LDL-C level. So those 5 to 10% who may have some reaction, some studies show less than 10% of patients are intolerant. But again, we have to educate these patients, let them understand the benefit of it, and then once they understand, the side effects are less. Because the patient hear all kinds of things from church members, from friends, from family members, and so before they take it, they start having the reaction. So I think we just have to be objective, but the benefit far outweigh the side effects. Over.
Yeah, let me also add that, as Dr. Doku just said, this is not to say that they don't exist. Such patients don't exist. I actually also have a few patients who are not able to tolerate statins, and they are presently doing quite well on ezetimibe. It's more expensive. It's not readily available, but somehow we are able to give them the ezetimibe. So this is not to say that already I said it's not so common, but I mean, they are there. Such patients are there, but there are not many. Very, very few. Thank you. And
thank you, sir. I think we have a nice consensus on the expert opinion on that. Another question came in through the CES. It says, currently, will you suggest we include statins in protocol for managing CVA without results of lipid profile? So I think Dr. Mensah is asking if you can proactively add statins even before having the lipid profile of the patients.
Okay, Prof, if I may come in here.
Yeah, go ahead.
Okay. Yeah, so this person who has a CVA or has an MI has had an event already. So whatever level of the LDL-C level, has caused an event. Was it 1.9? Was it 2.7? Was it 6.5? You know, so for secondary prevention, the guideline is clear. So for such patients, you need to give high intensity statins, and you're aiming at 50% or more reduction. And if you're not to target, then you can look at adding ezetimibe or inclisiran to get to target. So we've had a lot of problems in Ghana. The National Health Insurance Scheme, when you put a patient on statin, especially for secondary prevention, you know, they want to know the LDL level before you started. You know. So it's neither here nor there. And as you saw, for secondary, for somebody who's had recurrent events, you're looking at LDL level of 1.4, or you know, somebody who's had 2 events in the last 2 years, you're looking at 1.0 millimoles per liter. So here you need a high intensity statin in addition to the lifestyle modification, and then in addition to, you know, other medications to be able to get to target. So it is very important that you can give, whether to check the LDL level or not. We will recommend you check so that you know what the baseline is, and the guideline is recommended that 50% or more is what you need to achieve, you know, and a clear target. So yes, even though it's secondary prevention, you still need the LDL level to know. Even if it's 1.4, that's what has caused the infarcts, you know, and the guideline recommend that you reduce that level by 50%, and you need to do whatever it takes to be able to get to that. The other question maybe I may also ask, probably along the line, is how low is low? You know, some patients LDL level of 0.6, and then you have other consultants coming in and say, no, this patient is going to die if the LDL remains, you know. So probably when in responding to this question, how low is low? Over.
Okay. Thank you very much. I think you answered the first question quite straight away. No need for me to say much about that. Because for as long as there is a possibility of atherosclerotic cardiovascular disease, really patients should receive statins, unless if they cannot tolerate them. Considering how low is low, I have seen patients with LDL cholesterol below 1, and really, and you know, most of the time, these are patients that have been on statins for a very long time, you know, high dose statins. So my first reaction, really, if it goes below 1, is just to reduce the intensity a little bit, take my legs off the accelerator, you know. You know, let it be, if, for example, the patient is on 20 milligrams of rosuvastatin, I will reduce to 10 and allow the cholesterol to, you know, to probably, I mean, the patient is probably doing very well, no need for the very high dose. I think that's normally what I do. Occasionally, I think once or twice, I ask the patient, because I've seen this in about a couple of patients, like 5 patients or so. I remember 1 or 2 patients, or among the 5 or so, I gave them a break. I stopped for a month or 2, rechecked the cholesterol, and for sure the cholesterol, you know, went back, you know, to higher levels. So I just restarted, and that is what informed my strategy of just reducing the dose rather than stopping. So I normally don't stop nowadays. I may reduce the dose if the LDL is below 1, and all the others are also within normal limits. So that is when I reduce the dose. Otherwise, it's cause for celebration that the LDL is below 1, is below 1.4. Thank you. Over.
All right, so somebody, I will start before I ask this next question. I want to ask a theoretical question. If a person has an event at 1.4, would you still want to go with the international guidelines and try and, if a person still has an event, it's cardiovascular event at 1.4 millimoles per liter, would you still want to do what the guidelines say and reduce it by 50% to 0.7? Or you still just target that one? I don't know.
Yeah. So Yeah, so you saw one of the slide I showed, where it's 1.4, but for very high risk patient who, despite 1.4, you're still getting an event. Then you're looking at 1 or even below. So the guideline is clear, and these are based on large data, supporting the benefits of lower is better. So if the person has had an event, you need to prevent subsequent events. This patient are presented with 2 strokes and they come in with the MI. Now, if they to start with, if the LDSC was 4, we'll still go ahead and do whatever we can to reduce it by about 50%. So guidelines are behind us with a lot of data that level was still at a risk for these patients, and there's a benefit of reducing it further.
Thank you, sir. I think some neurologists tend to have a lot of thoughts about this, but I'm surprised that none of the neurologists on the call have asked yet. I think neurologists are a little bit skeptical of going less than 1.4, even if the patient is having risks. I think it has to do with the fact of the stability of the arterial walls to prevent hemorrhagic stroke for their patients and all that. So neurologists tend to have a difference of opinion. I don't know if you have any thoughts about that before just take the last question.
Yeah, so the benefits are there. We may have 1 or 2 incidents here, but the general consensus is that if the person is 1.4 and has an event, then you need to go a bit lower. There's this notion that when the cholesterol is 0.7, most doctors become jittery, but we shouldn't be. It's safe. It's still very safe for the patient, and you have better outcomes when you go low. And so this has been a debate, and for what we are saying about low is better, lower is better, 0.7, 0.8, it's been debated with a lot of data at ESC, at ACC, So those hemorrhagic stroke events, yeah, it do occur every now and then, but on the whole, if this may probably occur in 0.001% of patients who have very low LDL level. So it's not a norm, and the benefits are enormous. If the person has an event at 1.4 and you're able to come down to 0.8, the benefits is huge for this patient in preventing subsequent events.
Yes, sir. So the benefits outweigh the risks, which is basically every medical therapy that we ever take. Thank you very much, sir. So Dr. Igwe from Nigeria asked complemented representations again, and then he asked how you would rate inclisiran versus ezetimibe in order of priority.
Yeah, but if I may go first, the guideline, I mean, all the guidelines that we presented today, ezetimibe is the first to add. It is if the cholesterol levels are still higher than, you are not able to achieve the target LDL goal, then you consider additional therapy. So the first thing to add is ezetimibe. Of course, you titrate up the statin dose first, then ezetimibe, then additional therapy, which could be inclisiran.
Yes, sir. Thank you, sir. I think that is pretty straightforward. So they asked that with respect to lower limits, is there a specific lower limit for those above the age of 85? This is from Dr. Nanaya in Ghana. So is there a lower limit for patients above 85 years of age? Dr. Doku, I don't know if you want to take this, or is the answer still the same? Is there an age specificity to the lower limits issue?
Well, there is a publication that describes the benefit in elderly and the very elderly, and it's the same. Benefits are the same regardless of age. So I would say that the limits, the target LDL goal is still the same for everyone. The evidence there. Yeah.
Okay, then Dr. Amina asked, what would be one major drawback that might prevent a doctor from initiating treatment with inclisiran? So she wants to know if there are drawbacks to initiating inclisiran in any patients. Dr. Doku, Professor Kari, any thoughts?
Dr. Doku maybe, but I can say that we have to follow the guidelines as much as possible. I mean, you don't start with inclisiran, you start with statins, then you add additional therapies as the case may, as the need arises. Inclisiran is an add-on. You consider it, when you need to do that. Of course, it's very costly, so it's not something you just ask every single patient to start with. I mean, where it's available, it's quite costly. So it's not something you just ask a patient to just start taking. You have to weigh the treatment options carefully. Yeah, Dr. Doku may say one or two things in addition.
Yes, sorry, my line, dropped a bit, so I couldn't continue with the first question. I'm sure Prof responded to it. But the question of the inclisiran, yeah, the guidelines are clear. As we all showed, that the first line is statins and then add-on ezetimibe. But there are some patients, but I have patients in Ghana who are not tolerant of statin. And so inclisiran, they are on inclisiran. So the guidelines are like that if patients are not tolerant, then you can go inclisiran alone, and which will give you about 65% reduction in LDL-C level. Of course, and if you look at the benefit and the convenience, of injecting first, and then the second, the third month you inject again, and every 6 months, the convenience of not having to take drugs every day, and also the benefits of getting to targets with the LDL-C, is very, very important. But yes, you start with your statin, you start with ezetimibe. If you're not to take it, they add inclisiran. But if patient is not tolerating, then it will be good to look at that, as I've done with some of my patients in Ghana, where they don't tolerate, one person, even 5 milligrams of rosuvastatin, this so much muscle pain, so he's agreed that yes, it's going to be inclisiran injection, and he's happy to inject this, twice in a year, rather than taking this drug that will give me a lot of pain. So the guidelines are clear, and then for those who don't tolerate, we don't have any option than to put them on inclisiran that for better LDL-C targets. Over.
Okay, so I think we have one last question, and I think we've had a very good one today. This is from Dr. Samuel Tando. He's asking if you can elaborate on the effect of statins on patients with liver disease. So he wants to know if a patient has liver disease, what will be the approach with respect to statins? Professor Kari, you want to take that? Patients with liver disease and statins.
Let me start, and then Prof can add on.
All right.
Yeah, so there are some patients, you keep an eye on them. What you could do is, is not contraindicated. So if the patient has background non-fatty, non-alcoholic fatty liver disease, for example, you could still give and then monitor. You're not supposed to, you can probably go full blast. You can start, maybe 20 milligrams atorvastatin and see how this patient respond to. And as I mentioned earlier on, the benefits of statin goes beyond LDL-C reduction. And so that is really one that you need to initiate with. If the patient is on a medication, let's say atorvastatin 40 milligram or rosuvastatin 20 milligram, and then your liver enzymes start going up, what I would do is I will halve the dose and get this patient to continue with a half strength. So instead of 40, I'll do 20. Instead of 20 rosuvastatin, I'll do 10 rosuvastatin. And then, after 2 weeks to a month, I'll check the liver function test again. Clearly, if things are getting worse, then I'll have to withdraw and then look at, next line and or even a third line of starting therapy, But depending on the level, it may not be contraindicated. But if the patient is on it and then starts having abnormal liver function, then you may have to reduce the dosage and then see what the levels are and advise yourself whether taking the person off or you maintain on a lower dose. Over to you, Prof.
Yeah, absolutely. I agree with what you've said. The approach is quite obvious that you need to be careful with such patients. And sometimes you find that, in fact, the reason is not even the statin, is something else. But one needs to be cautious, always listen to the patient and investigate for possible side effects. So thank you. Over.
Okay. Thank you very much, Saz. We really appreciate it. I think we've had such a wonderful time at this session today. I think it's been very enlightening, and so we'll be going to the closing address that'll be given by our own Dr. Adeline. She's the head of medical and partnerships in Novartis Southern Africa. Thank you, everybody. Over to you, Adeline.
Thanks, Sam. Thanks a lot. I hope you can hear me. It gives me a lot of pleasure to conclude and close this program. I think it's been very successful, and I trust this has been as an exciting, educative, insightful, impactful session as it has for me. A lot of questions that I had have been answered, really. I think this program is coming at a very opportune time, building capacity and capability for ASCVD, dyslipidemia within Anglophone West Africa. I believe that it is essential for us to maintain the lines of communication, collaboration, engagement between Novartis, between the speakers, between the participants. A big thank you goes to our esteemed speakers, Prof. Karaye and Dr. Doku. I mean, we thank you for your expertise, for your time, for your commitment, for making this session as interesting and engaging as it could have been, really. I think very well done to both of you. I've really had a very good time listening, learning from what you've given us today. I think I would also like to thank my esteemed colleagues for working tirelessly to organize and facilitate this session. I think is a testament to their commitment and their passion, really. So yeah, with that, I would like to also thank the participants, both in Nigeria and in Ghana. I mean, time is of utmost importance to us all. Time is precious, but you've been here today. I thank you for the level of engagement, for participation, for your questions, and I'm hoping that you got as much out of it as I did, really. So with that said, I would like to bid everyone a very good rest of the evening, and hope to see you in one of our scientific meetings again soon. So thank you again, and good night.
Good night, everybody. Please use the links. Please use the links in the chat and the barcode on the screen to get your CME points. Thank you very much.
Thank you. Bye.
Thank you. Bye.
Bye, everyone.